Okay, this is the Siemens Somatome Definition AS. It's a 128 slice scanner. It's actually 64 detector elements, but they sample them twice, so they call it a 128. I'm just going to show you some of the basic controls and how you operate it. I'll show you the power injector and how to load some syringes, and then we'll do some positioning, some landmark things later on. And then we'll break down protocols on either another video or this one. So it's really straightforward. Every CT scanner is a little bit different, but the fundamental features are the same. So for this, it's just up, pretty intuitive, and then the table will raise. There are also foot pedals that can do the same. Now, I rarely use those because they stick and then the table doesn't work. So once you're at an appropriate height where the table can enter the gantry, then these other controls will light up. So some of the other features that you have are you can angle the gantry. So there is a tilt to the gantry if you want, and you can notice it'll move.
Oh, wow.
With helical scanning on a Siemens scanner, you can't have an angle gantry. The only scanners I know that allow you to use gantry tilt with helical scanning are Toshiba or Canon. They invented, or Canon bought Toshiba, so they're the same thing, but they invented that kind of helical algorithm for gantry tilt. Anyway, so we can tilt the gantry, and then you just can take the table in, take the table back out. Now notice, if I just hit the button solo, the table travels slower. This makes it move faster. And then it'll just shoot in when it's ready. Okay? And those are the features, in and out, gantry tilt, and then you can turn on your laser localizers. So every scanner is going to have two sets of localizers. You'll have an external one, so you can use this as a landmark, or you can have an internal one and use that one as a landmark. It doesn't matter which you use at all. So now you can zero it. So what zeroing means is it tells the computer that, okay, this is the 0 point. Everything superior to that is going to get a number based on its measurement above that, and every inferior will get below that, okay? So that's the 0 point. Siemens scanners don't use that. You localize to specific points, and the scanner treats that point as 0, essentially. So you don't have to worry about it on this scanner. GE, you do have to landmark, and you also have to landmark, I think, on the Canons. I haven't used the Philips in a long time, stuff like that. So, but every system's different. Just get familiar with that. So those are your basic controls. You can also do presets like A and B, and it'll just take them to that point. I don't utilize that. It's such a fast-paced thing. You just kind of knock it out. So this is gonna remove the patient and lower it. It's just kind of a quick button. You also have a panel by the PC that you utilize that has similar controls. So you can move the table from back in the control room. Okay, so that's some of the fundamental functions of the table. All right, so this is a power injector. You're gonna see this in every CT suite. We almost never hand inject. I've never seen drip infusions. Those are kind of a thing of the past, though your textbook does discuss it. The power injector will inject contrast and saline at specified rates. Those are protocol based, and you do have some liberty to adjust those depending on the patient, the IV access, and your trust and relationship with your radiologist. So this is a dual-headed injector, okay? So the blue is saline, the green is the contrast agent, and what you do is you load these syringes. Now, some facilities have pre-loaded syringes, but for this, we're gonna just drop it, push it down, and it's gonna bring the plunger up. So it's gonna load that up. And then you put these little spikes like this. I'm not gonna waste these because I'm not using contrast yet, but you put these spikes on here, drop your saline and your contrast here, and then it'll draw it up, and then you're good. These warmers are kind of a throwback. If you stick these warmers on here, then what you inject the patient with is a warmer fluid. Back in the day, they used to think that the warmer the contrast, the less viscous it was, so the less pressure it exerted on the vessel. So those warmers, in fact, they used to keep contrast in a warmer, but that's kind of a thing of the past too. So that's real simple. If you hit auto load, this is a MedRad, by the way. So there's a computer back in the control room that syncs with this and lets you set the protocol. But if you hit auto load, whatever protocol is pulled up on the computer will pull up here with the appropriate volume of contrast or saline. And then you can manipulate it here with these different controls. Like you can move the plunger here. If you hit move piston and do that, like I can draw this plunger back over here. And then I can push it back. And you can do that, and then once you've done that, once you've loaded your contrast, you hook tubing to this, and then the most important thing you have to do is prime the tubing. So you hit this prime button here, and it's gonna push 4 cc's of saline and 1 cc of contrast through that line, and then you don't have any air. You don't wanna inject air in the patient, right? That's bad. So you just wanna make sure there's no air in the system, and that's kind of the whole deal. And along the note, remember, 4 saline, 1 of contrast. That 1 cc will show up. So if you have a without contrast scan that you need to do, don't do a test injection before you scan that, or there will be contrast in it, okay? Like if you're doing a brain with and without, make sure you do the without, then do your test injection, and then you can do your with contrast study. Okay, so that's the power injector.
All right, so for this one, I just wanted to give you guys an example of loading contrast. So as you can see on the left hand of the screen, I have placed the saline. On the right is the Omnipeg 300. I'm just prepping for an exam. It's auto loading right now. So it's just pulling up the contrast to the specifications of the protocol. When that is done, you're gonna see in this video that I'm going to connect the tubing and prime the tubing. And I really just want you guys to see that. So I'm not gonna talk anymore on this particular clip. I just want you to see it, okay?
Okay, I'm going to show you some positioning of my wonderful model, Claire, here. Okay, she was kind enough to volunteer to let me show you guys some things. So I have her position, and the way we refer to this in CT is head first supine. So she's going into the scanner on her back, head first. Okay, so head first supine. This is going to be the positioning for most of your neurological work. Okay, so we're covering neuro right now. And it's really straightforward, all right? Most of this stuff as far as using the controls and setting the patient up is really fast. It doesn't take long. Now, I'm using my phone to record this, so I'm hoping you'll be able to see what I do. Every CT scanner is going to have different positioning devices, things that help make the patient more comfortable, all right? So if I'm doing this, I lay her down, I'm going to put this under her knees, okay? So I just go to my patient, raise your legs up, and set them right there. And so what that does for her is just kind of reduce that lordotic curvature of the lumbar spine, take some of the pressure off the low back. Remember, just like an x-ray, the more comfortable your patient, the less motion, the better the images, right? So communication and comfort are gonna go a long way when positioning the patient and getting them to do what you need them to do to get compliance or adherence to your instructions. Okay, so she's good to go. Some of the other things you can utilize, I got some sponges here, right? So like if I'm gonna do a CTA head, I'm gonna pin her head down with my sponges. All right, so I'm gonna put them on either side of her head, and then I've got these straps, if you can see them, right here, like this, that Velcro to the head holder, and I'm gonna strap her down and put sponges in because I do a without and a with, and I have to do digital subtraction. And so for that to work, she can't move in between or the images don't line up and I get bad images. So she has to be very still. So anyway, so that's some of the stuff. Neuro, especially at a rural hospital, is gonna be really straightforward. You're gonna do heads, you'll do spine work, C-spine, T-spine, L-spine. You'll do CT angiography of the neck and head, so the circle of Willis and the carotids. And then at some facilities, you'll probably do perfusions, like if there are strokes in, okay? But there's not, that's the gist of it, or the meat of neurological imaging that we'll do in our area, okay? I'm gonna go ahead and show you how I would position for a head and a C-spine, okay? So we'll just raise the table up and we'll watch Claire kind of come up. I'll get her at a decent height. Now, hopefully you guys can see the laser lights on her. Kind of depends on the lighting here. So now I want you guys to look at this. You have, I'm gonna poke on you, Claire. You have the light there on the side of her head, right? You want that essentially at her mid-coronal plane or right in front of the EAM. So if you can see where that is, that's where I'm gonna wanna be for her head. Then I'm going to advance her into the gantry. And the internal light is what you use on the Siemens systems most of the time. So I don't know if you guys can see this, but this light here on the side, right there, that needs to go above the vertex of her head. And the system is going to know the direction of my scan. And I'll show you that when we get into the protocols on the PC. But the important notes is this system cannot scan above this head holder. It won't, there will be no data. So if they're sitting too high up on the table, then you will clip the top of their head and you won't be able to get it on the scan and you'll get yelled at by your radiologist, okay? So I'm just gonna do that. Then I'm gonna go back to the computer and load it, and that's how I scan a head, okay? Now if I wanna do a C-spine, I'm gonna position the same because my topogram's gonna scan that whole thing. If you wanted to do a C-spine, you could come in a little bit and then raise her up. That's probably a better position right there, right? So now you can see that this light here by her ear is gonna align, oh, you didn't see that, sorry. This light by her ear is gonna align with her cervical spine. Okay, so that would be how I would start a cervical procedure. Same thing for my T-spine, right? I'm gonna take her in and my inner light is gonna have to be above T1. So I'll probably go to about C5 or 6, something like that, right? And then I'm gonna raise her up so that my light here, Claire, can you bring your arm up over here across your chest? Yeah. So I want that line here to align with her thoracic spine. Same thing for the lumbar, okay? So it's the same positioning for all of those. So this is a really simple thing, okay? So just keep that in mind. And since we're doing this, I'm gonna go ahead and break down all the rest of the positioning while we're here, okay? So now I'm gonna show you a different position that might be utilized, okay? Now, I want you to remember from the head first supine position, that's how we're gonna scan the head, the neck. We can do the T-spine that way. It just kind of depends on how they order it, right? You may do, if they order a head, neck, thoracic, I'm gonna do it all head first. When I get to the thoracic, I gotta bring their arms above their head and all that, which we'll get into a discussion with that probably on our Zoom meetings or as I go through the protocols, because it's complicated, right? But this is another position. This is feet first supine. This is gonna be most commonly used for imaging of the chest, of the abdomen pelvis, and of like just the pelvis or the lumbar spine. So that lower region below the neck. If that's all they order, this is the position you'll use. If they order like a pan scan, which is like head, neck, chest, abdomen, pelvis, it's a trauma scan, you'll just put them in head first and do it all that way. So you've got some flexibility, but let me show you some of the centering points, okay? So here's Claire going back in. Ma'am, can you raise your arms above your head, please? So Siemens scanners have that fancy little holder. It has like a cubby for their head and neck, and then their arms can go up there. Now, most of these are gonna be done with contrast, so this patient will have an IV and will be hooked to the power injector. All right, so we'll go ahead and turn our light on and we will take her in. I'm gonna show you guys here. You gotta love my videography there. All right, so notice I want that line on her side again, I'm gonna move your coat, to be approximately mid-coronal, all right? And that's gonna put her anatomy at ISO center in my scanner, and that's important. My inner light, this is for an abdomen pelvis, the inner light should be above the diaphragm. And as technologists, we need to know where that is, right? Let's see if we can see it on her. There you go. So that's about where her diaphragm will be. I might go in a little bit more because these topograms are the scouts that we do have a predetermined length, but I can change it if I need to. So that's where I'm gonna center right there, mid-coronal above the diaphragm. That's for an abdomen pelvis on this scan. All right, now if I take her in further, this is gonna be a chest. The chest I'm gonna center just like I would for a T-spine, except the patient is lower in the gantry, okay? I don't know if you guys could see that light. It's gonna be about at her thyroid cartilage, okay? So that's that's it for those. And if I was gonna do a pelvis, I very well might do an entire abdomen topogram. It just kind of depends. But that's it, right? A lumbar, I'm gonna go in just like I would for an abdomen pelvis, right? So there's my lumbar. If you can see it, my inner light is at the diaphragm or above. For a pelvis, I could do the whole abdomen on my scalp, or I could just go just above her iliac crest, something like that. Okay, so that part is really simple. Not a lot to it. You just use these controls, kind of get them where you need. Make sure they're ISO center as much as you can. All right, so that's that. All right, so I've anonymized some patient data. So none of this information is real. All right, this is Jane Doe. And I'm gonna talk you through what this scan looks like. All right, we've got a head, a cervical spine. I think there's a T-spine and an L-spine. So this is some general non-contrast neuro work. It's trauma related. This patient probably got in a wreck or something. I have no idea what's up with this patient. I'm gonna talk you through the entire scan if I can, and some of the parameters that you need to know and that you'll have to adjust, okay? I'm not gonna teach you in this how to use this scanner, because you may never work on a Siemens scanner. But I am gonna point some things out, and when you watch this video, if you have questions, kind of jot down a note and we'll go over it in the discussion, okay? Now, every CT scan starts with a scout, okay? Or a localizer, or a topogram. That's a vendor-specific term. Every scanner has a different term for it. So if we look, when I started this is like the video we did, right? I would have centered here above the vertex, and then I would have done a scout here. This is a lateral scout, and this is the AP scout, okay? It looks like they did a couple. If you look here, they didn't like their centering. So here's our AP, our PA, and this is our lateral scout. So let's go through some of the protocols here. So if you look down here where my mouse is, the mass and the KV, those are preset. You typically don't have to adjust those. It tells you how long it's going to take to acquire the topogram. It says the slice thickness. You're not doing slices with topograms, so that really isn't relevant. The length is important. So if I can't repeat this, but I want you to know this drop down here, you can modify that. So this is 1024 millimeters. And so that's why we get the whole body length. Typically, if I'm doing a head, it's just gonna be 256 or whatever. So you can modify this. You can also manipulate the tube position on your topogram. So that's why I said PA instead of AP. Obviously on the AP, that should be on the bottom. If you notice here, this is the AP topogram, and the tube position is on the bottom. Now that's gonna reduce orbital dose and breast dose and any of those anterior structures that are radiosensitive. So that's what I'm going to utilize, okay? So with the scouts, that's what you do. You really just you can manipulate the length and the tube position. Should be built into the protocol, may not be, okay? So again, know what you're doing here. Now we're going to jump into the first scan. This is a head. All right, so let's go here. Now look at this pink box. This is the scan range that I'm setting up. I'm going to look at the lateral. I like doing laterals on the head. So I've done my scout, and if it's just the head, it's just going to be up here. We're not going to see the rest of the body. So we do that. Now we're going to set what we call our scan range. It's this pink box. We want it to be above the vertex and below the base of the skull. Now whoever scanned this, notice you've got probably 2-3 extra slices here and up here. That's wasted radiation. It's not necessary. But if the patient's moving or whatever, maybe you want to provide them a little more space. So the way this procedure is going to go is I'm going to do my scouts. Then I'm going to set up my different ranges. Now, since there's multiple procedures on this one, I'm going to set up these ranges like all at once. But we're going to talk through like we're just doing the head first, all right? So I'm going to put my box below the base of the occipital, and I'm going to put the other part of my box above the vertex of the skull. Then there'll be a button. I'm going to load it. The system's going to say scan. I'm going to hit the button, scan, and it's literally going to take 30 seconds to do a head without contrast, okay? Super easy. So I get the scan, and then I'm going to get what they call, it'll be a box like this one, but it'll say RT. And it's gonna be a real-time image. So it's gonna scan from the base of the skull up. So I'm gonna see images as it scans, like, and these images are gonna pop up. They're not our high-quality images. I've still gotta reconstruct those. So, okay, so what I meant by that is when you first get these images, that RT down there is telling you, hey, this way you can scroll through and you're like, all right, does this patient have a bleed? Do they have an active bleed? Is there a stroke? All right, do I see those things? And on the RT, you're like, okay, no. And then what you're gonna do is you'll look at your pink box, you make sure you have all the anatomy in there. Now this pink box on this screen, this is your display field of view. So you'll remember that from the earlier chapters. This is your display field of view. You can manipulate it. Say I wanted to come in a little bit since I had the space. I don't need the nasal bone. Cool. Then I'm gonna come over here where it would say RT typically and hit recon. Now that's going to take the raw data and it's gonna apply the full algorithms. So we'll segue into that now, okay? Now I want you to look here. I'm gonna make a copy. So here, this is the kernel. On Siemens, it's kernel. It can be, it's the filter, like filtered back projection kind of stuff, or the iterative reconstructions. That's the algorithm. This is the filter we're using. We can select different things and it will change the way the image looks. So if you noticed, it was set to H31F medium smooth. We're gonna make this like a high res bone. It's gonna be ugly as all get out. So you can apply the kernel, and then you can do the window. Right, and the window is going to be another filter they're going to put on it. So we're going to go to a sharp bony algorithm, and we're going to use an osteo window. All right, but I'm going to go through the other details before we do that. Then we have our slice thickness. Okay, so again, that is something you can manipulate. Now look, we're on the recon tab, so that's important that you know. There's all these tabs. We'll go through them all. You can manipulate your slice thickness. We're going to go with thinner slices on this bony reconstruction of the skull. We're going to do. The field of view, it's telling us that. It's giving our centering point and all that. The mirroring is like, depending on like if they're scanned prone, you're gonna mirror both so that the images are labeled appropriately, right and left and stuff like that up here. Anterior and right are labeled if you look at that, R and A. Gives us our beginning and end position. We don't worry too much about that. The image order on the reconstruction, your radiologist is gonna wanna read that either head to foot or foot to head. So caudal cranial is from the bottom to the top. But you can reconstruct them top to bottom, it just depends. So slice thickness and increment, those are going to be the same so that we get contiguous slices, meaning 3 millimeters, 3 millimeter table movement. There's no overlap, but there's no gaps either, okay? And then it tells us our total number of images. So that's this tab, gives you quite a few things you can manipulate. We'll go back over to the routine tab. So this is the tab that comes up before you scan the patient. It gives you your effective mass, because it will modulate the mass. On some of these protocols. Gives you your KVP. These are pretty standard, and your scan time. It's also going to be dependent on how many slices you choose. Okay, so this is all kind of just going to be a byproduct of how I set up my ranges and all that stuff. So you don't have to worry about it. This one here is important to note. It's going to use 40 detectors that are 6 millimeters thick. Okay, so that determines like how fast we can scan. Now, if we were in a real patient before we've scanned, I'd be able to do a drop down here, and I can do up to like 64 at 0.6, or I can do 128 at 1.2. Now, this 0.6 millimeters, if I go back to the recon tab, that's the lower limit of what I can reconstruct. Okay, so I can reconstruct all the way down to what it was acquired at, and this, this is actually what the dose is based on. Okay. Because it's going to use enough to get me diagnostic images down here at this thickness, okay? Not at this. This is the reconstructed slice thickness. This is the acquired slice thickness, and that's important to note, okay? On these multi-detector CT scanners, this is what really matters. This is an illusion we can manipulate as long as we have raw data, okay? And now if I use the 1.2 millimeter slice thickness, well then that would be the lower limit and as thin as I could reconstruct, okay? Again, total number of images, all this other information we'd be familiar with. We can manipulate the table from here. If we go to scan, so on heads, these are important to know. Remember when we talked about dose modulation? Care dose 4D is going to be the tube amperage modulation, so it's going to adjust the mass based on this topogram here as the thickness of the patient. So when it hits here, it's going to increase our mass so that we remain diagnostic and reduce noise, so we keep our signal up. Care KV, when it's turned on, it's going to also modulate the KVP of the system. So you get these features here. It's going to affect the CTDI volume and the dose length product. So these are all components of dose. We'll get into that here pretty soon, actually. Okay, so note that. And again, these all repeat. Now, pitch is super important. Now, we talked about pitch early in the semester. This has a pitch of 0.75. So it is less than 1. So it has a higher dose than a pitch of 1. And you got to remember, helical pitch is like that slinky that stretches out. So this has a little bit of overlap in the tube motion versus the table movement. And that's going to affect dose significantly. And then the rest of this is just pretty straightforward stuff. It's just repeats of everything else. Here's something good to note, the rotation time. So this is saying here that the tube takes 0.5 seconds to take a full rotation around the gantry. That's really fast. You know, there's a video on the internet of a CT scanner with the gantry cover removed, and you see how fast that apparatus moves. It's kind of ridiculous, but that's a fast one. This 2 seconds is saying after I hit scan, it's going to count down 2 seconds before it scans. The API here is just like on an abdomen pelvis, this is going to be the breath hold. And you can pre-program these. Take a breath in, hold your breath, and then you can select your own voice if you want from there, and then it'll tell them to hold the breath in the way that you recorded it. And then you can choose different languages as well. Auto tasking is the final feature. I don't worry about any of this because we don't film anymore. But the requested procedure. So what this is saying is if you look here under head, the head needs to reconstruct into the folder of head and not of thoracic spine, because that's going to be an issue. It's going to go to the wrong folder and it's going to be a mess on PACS. So if you use the Siemens, just make sure that's right. Most of the time it pulls with the protocol, it's preset, but it can get scrambled when you get like uncommon combinations, like a PE ordered with an abdomen pelvis. That can mess up, so just make sure that's right. You need to do it before you scan, before you reconstruct. All right, so that's our tabs down here. Those are some of the variables we can manipulate. Now remember, we changed the window, so I want you to take a quick look at this image here. We can see that this one was reconstructed with that H31F, right? So it looks like a regular brain scan. We've made this super sharp and done an osteo window. So this is my box, this is what I'm doing. I'm gonna hit recon, and we're gonna get a different scan now, okay? Look how sharp that is, right? It's super noisy, you can't see any of the brainy detail. Now, that's the algorithm. Now, watch what happens when I change our window to a bone window. We should be able to see significant bony anatomy here. Let's do, sorry, not osteo, I want bone. So look at all the detail here. I made them thinner, we can see here. That's an, God, you know, 7th and 8th cranial nerve. What is that called? An IAC, I'm sorry. Those are IACs, the internal acoustic canal. So sometimes that's a specific scan you'll do, but you can see the nerve, you can see the cochlea. All that detail is beautiful, right? Here we have the other one, the mastoids. And so the rads can look at this and see all the bony details. If there was a fracture, you know, you can even see the sutures here. So it's wonderful detail. This patient didn't move, so we've got great orbits. You can see the nose, the nasal bones, all the sinuses. Like this is a great window, right? There's a lot of detail, or a great algorithm. So we can do that. All right, I'm gonna show you another thing. It's different. I'm gonna add a reconstruction we get 8 reconstructions per scan. I'm gonna make it a 3D. So now we're looking at, if you look here, these are MPRs. Again, all the other features apply. We're gonna go ahead and make a coronal. So I click coronal down here under the recon access. I move my little box. I'm setting my display field of view on this. I'm gonna come into the posterior and anterior borders here. And then I'm gonna look at my brain, right? We're gonna make it where it aligns kind of through most of the mass. So that's how I would do my coronal. And this is an MPR, a multiplanar reformation. So it's a recon, but this is really a reformation. It's gonna use the scan data that's already there and reformat rather than reconstruct. It's what it's supposed to be. But either way. So I'm gonna hit that and we'll look. And now we'll have a whole nother plan. And that's what's so cool about helical scanners is we get a volume data set. I can reconstruct obliques, sagittals, coronals, and any variation I want. As long as the raw data remains, I can do anything I want to do. So we'll do this reconstruction real quick. And honestly, that's the deal. I probably won't go through the rest of these non-contrast scans. Maybe I'll touch them real quick, but not much. So here's we used our same algorithm. This is our coronal. We're gonna go ahead and change the window to the bone window because I like that one. Well, over here, I was on the wrong one. There. So look, Look at this detail. It's freaking sweet. Here's our IACs again. We can see, let's go up to the face. But yeah, you've got gorgeous orbits, frontal sinus, nasal bones. I mean, these are just really pretty pictures. I don't know why we don't do these for facial bones. This is way better. Anyway, so it's real pretty. And we could go all the way down to 0.6 millimeters and have a ton of images that the RADs would be responsible for. So that's our head. If we look at the neck, the C-spine, I set my box up. I'm gonna go from above the EAM down through T1, and then this is what I get. If we look here, the algorithm here is B50. Let's go here. Look at the recon, B50 medium sharp with bone, 2 millimeter slices, 2 millimeter increment. And we scroll through as soon as you see ribs, you can stop the scan, because that's T-spine. You do that. Now on your on spine work, you always do coronals, right? Because you need to see that. Like I would have angled this more. You see how you don't see all the vertebrae in one image? I would have angled that more, so I saw them all on a column. I'll show you what that looks like. So if you look at the spine here, how they have it set up, that's how the slice is going to angle through. So I would have hit them with this, okay? And I would have tightened this up here for my display field of view to be a little cleaner. I'm going to recon that and go through the sagittal with you. On the sagittal, we want that image. All right, you see how it blurs here? That's because of the shoulders. That's a noise. That's the noisy part of the image. It's like that on every one of the C-spines. We got 2, 3, 4, 5, 6, 7, T1. We're square. This is it. It's going to show. This is the view you're going to see an odontoid fracture on, really clean. A good coronal will show it too, but this is always the odontoid. You get a beautiful dens on that. While we're waiting on the cervical recon, I'll jump over to the lumbar. Now you'll notice the lumbar slice thickness is thicker because it's a bigger bone than the cervical spine. But again, we just scan halfway through T1. I don't know if you can see that. I'll zoom in. So you're halfway, or T12, halfway through T12, and then down through the sacrum. Now notice the patient's hands are here on the topogram because I scanned the head and neck first, the hands are down. When I actually do the scan for the T-spine and L-spine, the hands go above the head. So you just kind of tell the patient to move. All right, so here's our lumbar. You can just see the images, right? These dark spaces here are the disc spaces. And if there is some protrusion there, you can see that. But really, we're looking at bony alignment. And the integrity of the bones. Like, so you'll see all this, you'll see compression fractures if you need to. And we got our sagittal again here. It's pretty. That's a really pretty spine. And then T-spine's the same way, all right? So I'm not gonna go through it too much. Let's look at this, at least the scout on the T-spine. So if you look, we're up here in the cervical spine, and then they're right through L1 on this. So if you look, that's L1, you can see the 12th rib there. So they've got the entire T-spine on their scan. If we look at the lateral topogram for the T-spine, we'll see these are a little harder, right? I probably would have raised that a little higher. That doesn't quite seem like T1, but yeah, so T1, and then again, 5, 4, 3, 2, 1, through halfway through. So we want to verify that. On the lateral, what you worry about is the anterior-posterior placement of the box, right? So you can see that the head box is way up here anterior. You need to make sure before you do your reconstructions, your final recons, that the box is in alignment. All right, so let's look at the coronal I did. So we really want to see that. Okay, do you see the difference here? How these are all in one picture? That's beautiful. The odontoid is beautiful. If you look at the one they did previously, you see I'm scrolling through and I'm not getting that full column. So make sure the angles are right and do that. That's gorgeous. All right, so that's it for head, neck, and spine. I'm sure you guys will have questions. I just wanted to give you a rough run through. Yeah, so there you go. Thank you. So I want to talk to you guys briefly about CT angiography of the head and neck. This is a really common procedure that is ordered after a stroke protocol or just a CT head without contrast. Okay, so this procedure is just to evaluate the vasculature of the carotids and like the circle of Willis and some of the vessels in the periphery, the arterial vessels in the brain. So to do this procedure, what you do is it's basically just the head and neck without contrast.
followed by a rapid injection of IV contrast, and then another scan of a with contrast in the arterial phase. Okay, once the procedure itself it's so fast. What's really important is that the patient doesn't move between, like I said in a previous video, between the without and the with contrast. It's a CTA, so it's an angiogram, meaning that we utilize Omnipaque 350 instead of our standard of Omnipaque 300. Again, it has the higher iodine concentration. So we scan the without, we do a test bolus, then we inject 80 cc's of 350 at 4 cc's per second. A fairly high injection flow rate, and so because of that we use an 18 gauge IV, and then we scan the with contrast very quickly. We bolus track in the aorta for this procedure, so and then it triggers and goes. So with that being said, it's pretty straightforward. Once we get the images, we actually send them to a 3D digital subtraction angiography workstation, so we can pull the bone away from the vessels. So we subtract everything out except for the vessels, essentially. So sorry, I'm looking away. I keep looking at my tracker. So I'll show you that as well. With that being said, we'll stop, and I'm gonna go into the protocol so you guys can see what it looks like on a scanner. Okay, so let me walk you through this CTA head and neck on Mrs. Jane Doe. So again, for this one, we're gonna start with our topograms of the AP, or the PA, and the lateral topogram. You notice that the ranges cover the same ranges really as the regular CT head without. We might go a little lower here so that we can get the vertebral arteries going up to form the basilar. But mostly it's the same. And then the scan range for the neck is actually going to go from, if I can find it, is going to go from the aortic arch, because you need the carotid takeoff. So it's going to go from the aortic arch, and you'll see the bulb here. So you have to be below that on the neck, and then it needs to go through the base of the skull about to the EAMs, like where the top of the cervical spine would be when you image that. So again, from there down through here, so you can see that. Now, I know it looks like these are separate scans, the head here, that pink box, and the neck, but they are not. They're actually scanned all at once because the timing is really important. You have to get it all in one take, or you'll drop out of the arterial phase and miss it. Now this is just a without, but it's still going to be scanned in one lump. The reason the boxes are separate is because we're doing separate reconstructions, one for the head and one for the neck. But again, they're scanned as one group. Okay, but because we have a volume of data, it's a helical scan, we can then break it into its independent chunks, and then auto task the neck is selected, obviously, and that goes to the neck. When we select the head, that goes to the head. So that allows us to put the exam in the appropriate slot on PACS, but we can acquire it in one chunk, which is necessary for this examination, just so you know. All right, let's talk a little bit about something we really haven't covered yet: bolus tracking, what it is and how it works. So bolus tracking is our ability to place a region of interest in on a specific slice, and then have our scan begin at a specific time after that region of interest measures a certain Hounsfield unit. It's a mouthful, but check it out. So we set this line, this orange line here, we set that near the aortic arch or the descending aorta. Then we take one picture there. The scanner will move to this location and take a single image. This image to the right, this is the image we got when we did that pre-monitoring slice. That's what Siemens calls it. So we got this one slice. This is the descending aorta right here. So we click there, and then it'll give us an option to accept that location somewhere down here. So we click accept, and then what that's telling the machine is to take a picture right here every certain amount of time and measure the Hounsfield units within that region of interest.
Now that's what the monitoring does, okay? So look at the monitoring. Let's look at the protocol here. So it's going to wait 10 seconds. If you can see that delay there, it says 10 seconds. So we're going to start our injection on our MedRad at the same time as we hit start on our scanner, okay? And then that 10-second countdown is going to start. At 10 seconds, we're going to get images in the descending aorta. Now you see this is the first image. It's measuring 35 Hounsfield units. The second image is going to measuring 67, 97, and then it is set to trigger. If we look at the trigger tab here, it is set, well, it's because the scan is done. It's set to trigger at 100 Hounsfield units, okay? So if we look, this is at 97. It still hasn't scanned. It takes one more, 1 second later, and we have 145 Hounsfield units. Then the scan triggers. And so if we look at this scan, this is the actual CTA angiogram with contrast here, this bottom tab. It has 2 seconds to count down before it scans. Okay, so then it's going to scan from the below the aortic arch through the vertex of the head. And then we're going to get our angiographic images. So if you look at the first images, there's no contrast, right? It's just really kind of a mushy algorithm, but that's important for the CTA because we don't want gray and white matter differentiation on this one. We want just something to subtract from the angiogram. So now when we come down here to the angio, the with contrast, notice the arterial phase. So here is a beautiful image of the circle of Willis. Right here, we can see it all connecting here, the circle, cerebral arteries and whatnot. We can scroll down and we can see the vertebrals coming up here and here and our carotids as well. And then we can see them come up and merge. So that's the scan. It's real straightforward. The slices for what we send to the radiologist are 3 millimeters, but if you notice, there's 0.75 millimeter slices that are required as well. For these really thin slices, these are the slices we utilize to send over and do our digital subtraction. So those have to be recon. That's why you have this head without here, 3 millimeters, and then a reconstruction at 0.75. So we do that for the without as well as the with, and then we send that over. The algorithms and whatnot aren't as big of a concern on this from a practical standpoint, okay? With the with contrast, we typically do coronal imaging as well, if I can find it, yeah. That's labeled incorrectly, it should say with, obviously, but there's a coronal with contrast. Okay, so these we've done our withouts, we've done our with, we understand the bolus tracking. Let me show you the digital subtraction angiography, okay? Do note though, the 3 millimeter slice thickness is different on this than a regular head without. A regular head without is at 5 millimeters. This is 3 because you can see, you need to be able to see the vessels, right? And you have a 2 millimeters possible to miss something on the 5 millimeter slice. Vessels are smaller structures. It's important that we use thinner slices. All right, let's go over to the workstation. Okay, I want you guys to note this. I just brought in the without contrast and the with contrast head, okay? So now it's thinking. If we look here at what's going on with this workstation on Jane Doe, we'll see, we can't tell, but these are superimposed images, okay? So I can manipulate these. If I click here, it's going to allow me to turn or move it down. So we see how the with contrast is stationary and the without is movable. So I can angle these in any direction I want to manipulate the subtraction, okay? Now I messed it up, so it's gonna be way off register. But this is nice because if the patient's head shifts a little bit, then we have the opportunity to correct that so the subtraction functions better. But yeah, now we're way off, like on the subtraction. But if I go to this and we look here, now you can see that all that remains really is the circle of Willis. The vast majority of the bone is gone. And then I can spin this around.
and I will take this data set and send it back to my scanner computer, and I will spin it. I'll go ahead and show you. I think this will allow me to build a spin. So let me go ahead and show you what a spin might look like on this one. Where are the spins on this puppet? Yeah, so this scanner doesn't, this particular workstation doesn't allow for me to create the spins. So I'll go back to our other workstation, pull up the spins for you, and just show you kind of how cool it is. But look how pretty these vessels are and how clearly we see that. This is a wonderful study. It's beautiful. And we've caught plenty of like strokes and vascular anomalies on scans like this. And just another note, you're gonna have to know this anatomy really, really well for your CT registry. All right, I'm gonna close this down and go back to the other computer. So this PC has, or this software, it's Siemens Singo software, has a variety of tools. It's pretty impressive. And this is not a course on how to use those tools. You'll have to do applications training. When we bought this scanner, I actually flew out to Cary, North Carolina for a week, and they've got a whole campus with classrooms, and hopefully you guys get the opportunity to go get that kind of hands-on training at whether it's GE, Siemens, or any of the facilities. They have experts, the people who built this stuff, put on courses on specifically on how to use this software. But this is this is the post-subtraction data set, and I've loaded it into the 3D card here. And now I can turn this into a MIP. And this is the same thing basically that we saw in the other one. Now, if I were gonna do this for real, I would likely cut out some of this soft tissue, maybe the superior sagittal sinus here, and some of the venous structures, so that I was left with just the arterial. But check it out. So we'll fix the orientation here. I'm gonna do a MIP spin. So let's do a spin. We usually spin these in a couple directions, but I like this spin better. So if you notice here, it flipped it to kind of an inferior superior view. This image down here is the one I'm gonna see, so I'm gonna window level that a little bit. So you can see this one at the bottom, it's super bright, it's pretty. If I start, that's the spin down there. And then I can just load that in my viewing card and check it out, or I can just save it and send it to PAX. So it's pretty slick. I'll make it a little bigger for you. Maybe. I think I might have froze the computer. There we go. I'm gonna go ahead and save that because these are images that are done. It should be loading. Oh, I'm sorry. Let's just make it big and I'll spin it for you up here. Y'all forgive me, it is 3 a.m. and I am at work. This is my first night shift and I am worn slick. Anyway, check it out. Look how pretty that image is. And then the spin is just gonna spin it around a more focused axis, but yeah. You can see everything. Anyway, you can do all sorts of stuff. You can cut out little pieces. This is called segmentation. So when I opened that tool, it actually cut it out for me because it was based on the previous bone mask. So you can see they removed all the soft tissue, and you're really left with the major arterial structures of the brain. I hope that you guys get to play with this stuff in the future and get really good at it because it's a cool skill to have. And I really enjoy it. That's the kind of stuff I can nerd out on. Anyway, yeah, so there's your CTA head and neck. Hopefully that's helpful and it kind of brings it to life for you a little bit. Yeah, so again, let me know if you have questions and I will be talking to you all soon.